Good day, Steve Anderson here. Good to be with everybody. Our webinar will start in about 5 minutes at the top of the hour. You are in listen only mode. That means you should be able to see me and should be able to hear loud and clear. So make sure and turn your volume up. You're in listen only mode, which means you can hear me. We cannot hear you, which eliminates background noise so that everybody can listen without interference. If at any time during the webinar you have questions, you are welcome to enter them in your question box on your control panel. We may be able to deal with some of those questions today during the webinar. If not, we will respond. So when you enter a question, please include your name and your email address. And depending on our timing today, then we will answer those questions either individually or out to everyone who has participated in the webinar today. The webinar is being recorded and will be posted at crowncouncil.org in the training section under the webinar, training tab under the webinar section. Will be posted later today. And if you are registered for the webinar, you will get an email with a link to that recording. A couple of announcements as we ramp up here to get started. First off, great, amazing things happening in the Crown Council. Just some heads up here and some reminders. The 2020 Young Dentist Program is open for enrollment. We have had years of great young dentists. We just wrapped up the 2019 Young Dentist Program with some amazing patient results. And the Young Dentist Program is open to any dentist that has been out of dental school 5 years or less. So you are welcome to get onto youngdentistprogram.com. And at that point, you can see all the information and enroll. So if you have a young dentist in your life, or if you are one, come join us for the 2020 Young Dentist Program. 25th annual event of the Crown Council is coming up in January. And you can go to ccannualevent.com for all the latest information, including the 25th annual event awards. Nominations are being accepted up through the end of November, the end of this month. So November 30th is the deadline. So make sure and log on to crowncouncil.org and nominate your favorite team member, dentist, for all the different award categories that we have. It's one of our favorite parts of the annual event coming up in Nashville in January. Crown Council humanitarian expeditions for 2020 are almost full. And we have teams that come from all over the country to participate in the humanitarian expeditions that we have in the Dominican Republic and also in Guatemala. So feel free to call the Crown Council office, the number's on your screen, for more information and how your team can participate. Finally, new qualified member resources. So we encourage every Crown Council office to be a qualified member office. You can go to the Culture Works section of crowncouncil.org. There are a number of new resources there where you can become qualified, including the fast track resources to become a qualified member office. Things that every practice should be doing, and a way for you to be recognized for being a quality practice. Finally, our total patient service courses for 2020 are rolling out, including No More Hygiene, Total Immersion, and our Leadership Academy. So you can go to totalpatientservice.com for dates and locations. We'll actually be talking about a couple of those today during our webinar. So with that, I believe we are good to get started. So our topic today, again, is changes in clinical hygiene. and what your entire practice needs to know now. So our topic today, yes, has to do with hygiene, and it includes everyone in the practice. There will be some resources that we'll roll out today, some things that will help take your practice to the next level. Again, not only in hygiene, but your entire practice. As we go along, if you have questions, feel free to type those questions in the question box in your control panel. Please include your name and your email address. We'll try and include answers to as many of those as we can. Those that we're not able to, we will follow up with a frequently asked questions from the webinar later to every participant who is registered for the webinar today. I'd like to introduce you, for those of you that have not had the privilege of getting to know Tanya Bailey. Tanya is one of our practice advisors, one of our top practice advisors at Total Patient Service. Tanya's been in dentistry her entire career, and she spends her days all over the country in and out of practices, implementing the highest levels of practice management and patient care. She will share, along with me today, the resources, the new things that are going on in hygiene that you can implement in your practice to make a difference with your patients and in everything you do every day. So with that, Tanya, welcome.
Thank you, Steve. It's great to be here, and looking forward to sharing some great new information, as well as some great information on how to communicate with our patients, as well as how we keep score. So with that being said, I wanted to have everyone kind of think back to when you were in school. All of you had opportunities at an earlier time in your life to think about your ambitions. And if you're like me, in those early years, whether it was at school or if it was even the early part of your career, I would hope that every one of you as Eagles were hoping to be the very, very best. In fact, I don't think anybody starts out their career or is in school thinking, I just want to be mediocre. No one's thinking mediocre or average. We're thinking about being the very best. So when we think about being the best, we have to think about what it's going to take to continue to be the best. And Steve, I don't think your PowerPoint is showing, just so you know.
Yeah, I am working on that, so
okay.
My apologies.
There you go. So we'll have some great pictures for you in just a minute. But when you think about being the best, what got you where you are today is likely not going to be what it takes to keep you going where you want to go in the future. So we have to talk about what's old and what's new. So things that you learned in hygiene school, things that you learned in dental school, whether it was last year or 10 years ago or many years ago, over time we know that things change. And one of my favorite quotes by John Maynard Keynes, who was a British economist, was, "The difficulty lies not so much in developing new ideas as in escaping from old ones." I think that's worth a repeat because I think it's really profound. The difficulty lies not so much in developing new ideas as in escaping from old ones. And we've all had the experience of getting comfortable with how we've done things. And I think we all recognize also that if we always continue to do the things the way we've always done them, then we're likely to continue getting the same results, which may be ideal and may not. So things to know, there are changes in dentistry coming at us fast and furious, as well as in the landscape of hygiene. And then there are things that have stayed the same for many years. And one of the newest things within the last 18 months or so is a new classification system for periodontal disease. And the latest update replaces the previous update that was all the way back in 1999. Now, I know many people practicing today weren't even in dentistry in 1999. So it's been a long time and it's overdue. And what is exciting to me about the new staging and grading system is it creates the whole health perspective, which we all know is the direction that dentistry is heading. So why new classifications now? Well, in 2017, there was a world workshop on the classification of periodontal and peri-implant disease and conditions, and it was co-hosted by the American Academy of Periodontology, or the AAP, that I think most of us are familiar with, as well as the EFP, which is the European Federation of Periodontology. The workshop's classification changes are the first since 1999, like I said, and the new system covers many factors in order to enable clinicians to form a complete picture of the patient's condition and to diagnose and manage it. So, you know, previously we were able to talk about AAP case typing, and I think many of you will be familiar with that. And it was basically based on where the patient was today or historical information. Well, now we actually have the ability to not only take a look at what's going on in the mouth, but that whole health perspective, and including what's going on with the whole body, risk factors, as well as how quickly the disease is progressing. So if we can take a look at how the staging and grading systems work, and I'm going to share some information with you, pretty rapid fire, and we do have some materials that will be available for you as resources after the fact. So if you want to, if you're a note taker, great, take some notes, but also rest assured that this is all going to be in a written format for you when we're finished. So let's take a look at how the staging and grading system actually works. So there's actually 3 steps to this. So the new classification system has 2 key components, identifying a stage and a grade of periodontal disease involvement for the patient. So according to the AAP, they report this new system provides a structure for treatment planning and for monitoring a patient's response to therapy. So those stages, they're going to indicate the severity of the disease at presentation and the complexity of management according to the Journal of Periodontology. And those stages range from stage 1 to stage 4, with the lowest number representing the least severe form of the disease. So we'll classify that as gingivitis. So the staging is determined by a variety of factors, such as amount of clinical attachment loss, percentage of radiographic bone loss, and as we go through the slides, you'll see RBL around the tooth, number of teeth lost due to periodontal disease, as well as the probing depth and the complexity of treatment. So that's the staging piece. The grading indicates supplemental information about the biologic features of periodontitis and incorporate a history-based analysis of the rate of periodontal progression. So grading includes assessments of the risk of further progression, analysis of possible poor outcomes of treatment, and assessment of the risk that the disease or its treatment may negatively affect the general health of the patient. So those 3 grades are grade A, which would be slow progression, grade B, moderate progression, and then grade C, rapid progression. Now those grades are based on clinical attachment level or radiographic bone loss, percentage of bone loss, and case phenotype, which is determined by the body's reaction to the presence of biofilm. The grading system also takes into account smoking and hyperglycemia in diabetes as individual risk factors. So step 1, so we're going to go through 3 steps together. And what that's going to do is allow us to put the patient in the appropriate stage, followed with the appropriate grade. So step 1 is your initial case overview to assess disease. Let's call that your screening. And this is going to be things that you're currently doing. So you're going to have full mouth radiographs, which continues to be the gold standard for diagnosing radiographic bone loss, and that's according to the AAP. Full mouth complete charting, so including your probing depths, your recession, your furcations, your mobilities, because as you will recall previously, when we're looking at staging, it's based on clinical attachment loss, which is going to be your pocket depth plus your recession. So those two numbers are crucial to have a complete assessment. And then the final piece in step one on assessing is missing teeth due to periodontal disease. So mild to moderate periodontitis is going to be stage 1 or 2. And then severe to very severe periodontitis will typically be stage 3 or 4. And in that handout that's going to be available after, it breaks it down more comprehensively. So if we take a look at the next slide, which is step 2, now we're going to establish the stage. So periodontitis staging intends to classify the severity and extent of the patient's disease based on the measurable amount of destroyed and or damaged tissue as a result of periodontitis, as well as assess the specific factors that could be contributing to the complexity of long-term case management. Initial stage should be determined using clinical attachment loss. If that's not available, radiographic bone loss should be used. Tooth loss due to periodontitis may modify your stage definition, and one or more complexity factors may shift the stage to a higher level, such as diabetes or other risk factors from a health standpoint. So if we can look at that next slide, that's got our stage 3 and 4 on it. Once we get to step 3, now we establish our grading. So grading aims to indicate the rate of the periodontitis, progression, responsiveness to standard therapy, and potential impact on that systemic health. Clinicians initially should assume a grade B disease and then seek specific evidence to shift to grade A or C. So let me just say that one more time. And this is, again, this is from the AAP and the EFP. So initially you assume a grade B disease, and then you seek evidence to shift either to the lower grade A or the higher grade C. So staging and grading help clarify extent, severity, and complexity of the patient's condition, as well as the potential rate of disease progression, predicted response to standard therapies, and then, most importantly, that potential impact on systemic health. They also encompass other aspects of periodontitis, including pattern of bone loss, tooth loss, furcation status, difficulty in treating, prognosis for tooth loss, and the degree of restorative difficulty and complexity. So while this sounds similar to what we've done in the past, it's more comprehensive, and it's important to remember that a periodontitis patient who has been treated and is now stable should not return to a level of evaluation and maintenance identical to a patient who has never had periodontitis. So what that means is, and we've heard this refrain before, once a 4910, always, because the 4910 is going to be our maintenance to keep that health stable. Wow, that is a lot of information. And it's exciting to me that our industry is really transitioning to whole health expectations. And having all of this information, number one, I believe allows us to better screen and treat our patients. Number two, better allows us to document more, if you will, like a medical model, so that we're truly documenting the condition and the prognosis for the patient, as well as allows us to have higher level conversations with our patients. So Steve is going to share with us, now that we know all this, how do we take this information and have conversations with our patients without using things like clinical attachment loss and radiographic bone loss? How do we communicate that with our patients? Steve, take it away.
All right, so let me share just a few things from the patient's perspective that might put all of the clinical things that Tanya's just shared into some context that'll help you communicate better with your patients. So the thing that I love about this upgrade if you will, in terms of how periodontal disease is categorized, is it's taking into consideration the patient's whole health. And here's why this is so important. We're not just looking at the patient's teeth and periodontal disease itself. We're taking the whole health into consideration in terms of how things are categorized. So here's what we know based on patient perception and what patients are looking for today. So many of you are familiar, because we quote this a lot, a study that we helped commission at the University of Massachusetts at Boston on patients' perceptions of dentistry and what they're looking for in their dental provider. And here's just a couple of reminders of things that the public said through this public opinion survey. 85% of those surveyed across the country said, in a sense, tell me more about periodontal disease. Now, they didn't use the word periodontal, they used other words, but the point was they're interested in the mouth, the whole health of their mouth. So patients want you to check for periodontal disease. You're going to have to term it something other than periodontal, because that's not a term that everybody's necessarily familiar with, but make it in terms that they can understand. But patients want to have a discussion about the health of their mouth, the health of their gums, and how that impacts their total health. Now, here's the next piece, is that 78% of those surveyed viewed their oral health as part of their total overall health. So they get it, that there's a connection between this and their whole health. Now, what they said was that 58% of the dentists or dental offices talk about whole health issues. So you see the gap. You got 78% view it as a whole health issue, but only 58% of the offices are talking about whole health issues, and only 51% are talking about the correlation. So the public is basically saying, we want to have a discussion about our whole health and how the health of our mouth integrates and how it impacts our total health. So what Tanya has gone through, staging and grading, it helps boost that as an area of focus, because now how you're categorizing the nature of the disease takes into consideration whole health issues. So if you're going to do this properly, you have to look at their health history form. You have to look at other health conditions, because that impacts how you diagnose and how you grade their periodontal disease. Here's another interesting insight that I think it helps with case acceptance, is that those who view their dental health as poor are more likely to rate their overall health as poor, meaning that they get it, it's connected, and it would be irrational for most people to say, you know, my mouth's a mess, but everything else is great. You know, I'm a model of health, just except for here. They get it, that it's all connected. So when you have a conversation about their whole health, they get that it's all connected. The periodontal disease is related to all these other inflammatory related diseases, like heart disease, like high blood pressure, diabetes, arthritis. All of these things are all interrelated. Now, as a reminder, this is a little bit of a disconnect and is critically important. And all the findings that came out of the survey, one of the things that came out of it from the patients was, yes, I want to know more about gum disease. Yes, I view it as a whole health issue, but don't tell me to floss, right? So like, just don't tell me to do that, which was a disconnect, right? Because if they're saying we want to know more about it, but don't tell us to do anything about it, in a sense, here's the key to this, which is flossing is viewed by most people as being less important than other health maintenance activities, because, and here's the key, it's hard to do. So when something's hard to do, we tend to discount it. We tend to place less importance on it because we don't want to do it. So this doesn't mean don't talk about flossing. What it really means is you can't dictate and tell people what to do. You've got to engage them. And that's really the message here, is this is a conversation with patients, not a lecture. So when you go through their health history, it's talking with them about their health history and their other health conditions. It's asking them questions about, has anybody ever shared with you the correlation between the health of your mouth and what's going on and some of these other conditions that you might be experiencing? It's opening up the door so that you can have a conversation and help them discover some self-discovery here of the connection and what you can do together to improve their overall health. So those are just some perspectives from the patient's standpoint. The door is wide open now to have more whole health conversations with your patients. And this whole protocol now for diagnosing and staging and grading periodontal disease fits so well with where patients are today. So with that, Tanya's going to walk us through what a healthy hygiene department looks like that is focused on treating the whole patient and in actually treating disease, not just cleaning teeth, but actually treating disease and helping America get healthier. Tanya?
All right. Thank you, Steve. All of this helps us, better evaluate the health of the patient, like Steve just mentioned, and it enables us to serve and treat them better. So how do we know when we're doing a good job? How do we measure the health of our practice, of our department, even of ourselves, and how do we keep score? So I love to say, it's not about the numbers, and the numbers tell us a story that help us better understand if we're winning the war really against periodontal disease in this circumstance. So when we're treating disease, what we know is that there are optimal numbers that we see as a measure in practices. So we created, if you will, a optimal health practice evaluation so that we could not only take a look at, industry averages, which I think by and large just lump the good, the bad, and the ugly all together, but to really look at the best practices out there and what those numbers are reflected in. And I will say, having now for the last 12 years gone in probably at least a few hundred practices, I find that prophy mill is really a symptom of approval addiction. So let's take a look and see where you stand, and we're going to walk through 9 different numbers that you can look at in your practice in the standpoint of optimal. And then I'm going to share with you what that number is, what it means, what we see for optimal, and then you can figure out where you land as a practice. So total hygiene production. So this is taking, if you took your total practice production and you separated out how much of the production is coming from doctor, meaning restorative, functional, aesthetic dentistry, and then on only hygiene procedures, how much is coming from hygiene. So for clarity, exams would not fall in this number. Exams are a doctor number, okay? So total hygiene production as a percentage of total practice production, optimal number is 35% or more. In fact, it is not uncommon in a practice that's truly treating optimally whole health from a hygiene standpoint and a functional and aesthetic standpoint to see this number even approach a 50-50. So if you look at your practice revenue, optimal would be 35%. The next number that has an optimal assigned to it is production per visit. So we know that if we were to take all of our productivity, all of our production rather, and divide it by our numbers of visits, that's going to give us an overall production per visit number. Now, there's a lot of ways to slice and dice this number. We can look at total practice production per visit, which tells a small story. I like to look at production per visit by provider and by doctors, providers, and by hygiene provider. And again, this is going to be hygiene procedures. So this will include your prophies. It'll include your any of your therapy codes. It will include x-rays, anything that's going to go under that hygiene code that's not an actual doctor's procedure. So an exam, you may take an impression in your operatory, maybe for an occlusal guard or something. And while that's fantastic for overall office productivity, it doesn't reflect the true production per visit for the hygienist. So our optimal number for production per visit in hygiene is 225 per visit. Now, there are many practices on the line today, and this number does take into account fee schedules. So when we look at optimal practices, even with contracted fee schedules, we find best practices are still hitting a 225 per visit number. Now, if you're curious about your specific practice, we can do an analysis and decide on what would be optimal for you based on your geographic location with your zip code fee analysis, as well as your contracted fees. The next number that we look at from an optimal standpoint is production per hour. Production per visit, production per hour sound kind of the same, but they are truly different. So production per visit simply takes out of all the patients that we're seeing, we divide the production by the visit, whereas production per hour is our available hours to see patients divided into our production. So this is going to also be influenced by openings in the schedule. So this is a better number for profitability in hygiene. If we are having a maximum production per visit combined with a full, efficient, and effective schedule, then we're going to have optimal production per hour. It is possible to have optimal production per visit, but suboptimal production per hour if we're not maximizing our schedule. So our optimal number of production per hour is 175. Now, that is also based on payroll. So we tend to look again on a case-by-case basis and look at hygiene productivity and hygiene hourly salary. And your true optimal number is going to be multiplying the hourly salary paid in hygiene by 5 to come up with what your true optimal number would be. So for example, if a hygiene salary was $40 an hour, then an optimal number would be $200 an hour, 40 times 5. So that's how we can truly measure profitability in hygiene. The next metric is the Diagnostic Percentage. So this optimal number just takes all of the visits in hygiene, again, this is hygiene only, and measures out of all of the patients that we have seen, new and existing, what would be the optimal number of patients who had a perio procedure diagnosed. And how we measure diagnosed is that it went into the treatment plan. And just for context, diagnosed codes would be your perio scaling and root planing codes, so 43, 41, and 42. Your gingivitis code, 43, 46. It would also include the irrigation codes of 49, 21. So it's going to be a comprehensive approach to a diagnostic percentage. And our optimal number there is 15%. So in any given time frame, and I like to look at trends of either months or quarters. If we looked at the previous month or the previous 90 days, if we were measuring optimal, I would expect to see 15% of the patients seen had had a new perio diagnosis. So this could be, again, a new patient. It could be an existing patient that you'd been seeing years that you made a new perio diagnosis on. It could be a perio maintenance patient that has been a number of years since you've done active therapy and you retreatment planned new scaling and root planing. So there's a lot of opportunities where we can boost that perio diagnosis percentage. Next number, once we diagnose it, is, are our patients accepting? So we know from, if you've watched the skill of the week, Steve has a fantastic skill of the week called the rule of 15. And we know that it takes up to 15 times to get 90% of patients to say yes. Well, optimal perio case acceptance, when we diagnose that perio in our practices that we're working with, is actually 66%. I was really excited when I was assimilating these numbers to see that our ability to convert the first time for perio cases is really high. And I'm super proud of that because that shows Everything that Steve just talked about with whole health expectations and communicating with our patients, that's working. And when we are in an optimal practice, we're getting 66% better of case acceptance on the same day of the diagnosis. Are you numbered out yet? That's 6 of our 9 numbers. We've got 3 to go. So our next number that we're going to look at is our overall number of perio visits. So what this means, this is a little more complex. If we look at our total active patient base, so all the patients that have come in your practice in the last 18 months, and then all of them who are over the age of 30. The reason we look for over the age of 30 is because all of the numbers published through the American Academy of Periodontology and the Centers for Disease Control are based on looking at a demographic of patients over the age of 30. Now, you may diagnose perio on patients younger than 30, and I hope that you do, but this number for keeping score, if you will, in measuring the health of our practice is that we would expect to see 35% of your total patient base over the age of 30 would have had a completed perio procedure in the last 18 months. Now, that could have been a gingivitis case, and they've come back into the prophy, which is fine. It could have been ongoing therapy. It could have been active therapy. It can be perio maintenance. So our optimal practice is the total number of perio visits is 35% or more. The last 2 numbers that we look at for optimal aren't about perio. The next one is actually fluoride. Today, more than ever, the standard of care that we see in best practices is a recommendation for fluoride for adult patients. We routinely have conversations. In fact, I just had this conversation out in California this week about who are the patients who are not a candidate for fluoride. And this would be my question for you to have at a team meeting. Rather than talking about who should get a fluoride, talk about who shouldn't, because that makes this a lot easier. And build your list. Like you might say an easy one would be edentulous. So people with no teeth don't get fluoride. Got it. That's an acceptable answer. Other patients who may not get a fluoride would be, this is kind of my profile I build. They have no recession, so there's no exposed roots. They've not had a history of cavities, so very low or no caries risk. They have no existing restorations, so there's no susceptible margins. No prescription or over-the-counter medications, especially no allergy meds, so we don't want to have any dry mouth. No treatments for any type of cancer treatments or radiation, anything that would affect the physiology of the mouth. When I just had this lunch question on Monday, the hygienist looked at me and laughed and said, well, that's about 1% of our practice.
Exactly.
So the big reveal, our fluoride optimal number in the practices that we work with is 80% or better. It is not uncommon for me to be in a practice that is even getting a 90 to 95% acceptance. So last number, we build the protocols, we have the good conversations, and we want to keep the patients coming back. So one of the most important numbers when you think about your hygiene practice is your hygiene reappointment rate. Patients coming in, patients returning. If you've been through a total immersion seminar with us, you've heard our purpose statement, which is create a happy paying patient who pays more than it costs to serve and who repeats and refers. So that repeating patient is where retention lives, and retention lives in hygiene. So our optimal number for hygiene reappointment, meaning they leave that appointment with a next scheduled hygiene appointment, is 90% or better. Now, when we look at active patient count over 18 months, keep in mind, if we schedule 90% of our patients today to come back in 3 months, and in 3 months, only 90% of them scheduled to come back, and then in 3 months, only 90% of them scheduled to come back, you can see even in best practices with 90% reappointment, we are still going to have substantial attrition. So working to keep not only reappointed, but committed reappointed patients is a huge critical success factor. So I hope these numbers have given you at least a starting point to evaluate the health of your practice. And remember, it's not about the numbers. It's about the patient care. And these numbers simply reveal your standard of care and what you believe about treating whole health. So now Steve is going to share with all of us some of the resources to take your practice to the next level, and he's going to tell you all about those. Steve?
Perfect. Thank you, Tanya. A couple of questions before I get into resources very quickly. The first one has to do with the insurance company. So if what gets diagnosed and treatment planned based on the best interest of the patient, what the patient wants, and getting them healthy is not what is covered by insurance, would you share with us your suggested verbal skills?
Okay, so if I'm getting what you're saying, so in the event we're having a conversation with the patient about their health, and there are some treatment recommendations that are being made, and we know that the insurance is not going to cover those. Is that the question?
That's it. You got it.
So one of my favorite questions, because questions are the answer and the key to overcoming or preempting an objection. I'm going to give you two approaches on this. The first one, if we know going into it, it's not covered, then I would ask the patient, as we move forward treating this infection, in the event that your insurance is not going to cover the procedures that you and doctor have agreed that you would like to do, how would you like to move forward? So in the event that your insurance is not going to cover the procedures that you and doctor have agreed on is best, how would you like to move forward? It has been my experience that we tend to assume if insurance doesn't cover it, people don't want to do it. And it's been also my experience that when we ask that question, we preempt the dollar objection and we move forward on a path to overcoming it. Now, if we don't know that information, we would still use that same verbiage, just it comes back on the back end if we find out later on, for example, that it's not covered. Okay, what else?
All right, next question. One factor when talking with patients about overall health is how their oral health connects with their overall health, like we've talked about. Now, what if they go to a physician that is not talking about the connection, and so then the patient questions the validity of what's being discussed when in the dental practice we're talking about the connection, but they haven't had that discussion anywhere else? A couple of opportunities here. And Tanya, I'd be interested in terms of chair side, how you would handle that. There is, and I'll just weigh into this, there's a great marketing opportunity here for the future of the practice, which is to reach out to the other healthcare practitioners in your community and do lunch and learns, sit down with them and their teams and have a discussion about where things are headed, what the research says, and share that with them and have a dialogue about how you can work together for the overall health of your patients. So someone's got to introduce it to them, and starting and taking a proactive approach where you can start educating your community is a great marketing opportunity that then could turn into referrals. From a chair side standpoint, Tanya, what would you say if I said to you, nobody's ever told me about this before?
Great. So when that comes up, one of the things that I love about one of the resources I know you're going to talk about, which is No More Hygiene, is we have a ton of published researched information. And so many of our practices will put together a patient handout with some of those resources, whether it's generally through a web link. And so for that patient who wants additional information, which is oftentimes more of an analytic or C-type patient, providing those resources so they're armed with that knowledge is a great tool so that they can then have that and then potentially have the ability to share that. I will also say I haven't experienced in any of the practices that I've worked with a patient stating that their physician isn't aware of those things. So I don't believe that that would be a normal thing that would occur. We tend to see it go the other way, where patients are coming in with their documents from their physicians looking for a clearance of health periodontally so they can move forward with some type of a medical procedure.
Excellent. All right, thank you, Tanya, for the insights there. Let me share some resources and things that you can do to take your hygiene part of your practice to the next level. First, the staging and grading things that Tanya has talked about today. We have put together a handout, a resource for this that comes from the AAP. We did not make this up. So that will be resident at crowncouncil.org when we post this webinar. Under the training tab in the webinar section, we'll send an email out to you today once that's posted, and this document will be posted with it. So you can download it, you can print it. It is all the updated information, so you can see exactly how everything breaks down and how you can stage and grade based on the protocol today. Next, Tanya's gone through some numbers today in terms of what optimal health is for a great hygiene practice. And if you would like an up close and personal comparison of how you today compare to optimal, there is a resource that we would be happy to extend to those listening today that comes in the form of what we call a practice growth analysis, where we can take your current practice performance, compare it against optimal, so that you can identify where the biggest opportunities are for growth. If you would like a practice growth analysis for your practice and specifically for your hygiene department, you can email answers@totalpatientservice.com and just make the request for practice growth analysis. You can put that in the subject line. And what we need to know is, of course, who you are, your practice. We would need to know your practice management system. This is a little easier to do with some practices than others, but we can sync up all the data, take an in-depth look, and give you some great feedback. So shoot us an email at answers@totalpatientservice.com, practice growth analysis in the subject line, your name, your practice, your practice management program and version, and we'll be back to you with some details about how you can do a practice growth analysis and compare your numbers with optimal, with what Tanya has shared today. Finally, everyone, I'm sure, is aware of our No More Hygiene course, Cure Disease, Save Lives, Grow Your Practice, which is based on all of the latest science in the diagnosis and treatment of periodontal disease and its whole health nature. The clinical part of that is led by Dr. Tommy Neighbors, who has spent his entire life studying and developing the resources for how to treat periodontal disease at the highest level. You can go to nomorehygiene.com for more information about that course. There are courses already filling up for 2020. We do them all over the country. And it is a great resource for those who want to take their hygiene department to the highest level and actually treat disease, not just clean teeth, but treat disease and dramatically improve the quality of life of their patients. So with that, again, Tanya, thank you for all of your wisdom today and sharing some new insights on hygiene. And again, this will be recorded. We'll post it today. If there are any remaining questions that we have not addressed today, we will send out an email with the answers to those questions. So thanks again for joining us today for our Crown Council webinar. We look forward to seeing you soon at the annual event coming up early next year, as well as on our next webinar that's coming up in January on the latest changes in coding for 2020. Thanks for joining us. Have a super day.
Thanks, Steve.